Welcome to the Just Hard podcast, where nurses have honest conversations about the hard parts of nursing, because hard isn't the problem, it's the process. We are here to help you think like a nurse, survive the hard stuff, and grow into who you're becoming.
Because it's just hard, and we can do hard things. Let's get started. Real nurses,
Real talk.
and real life.
I'm Chelsea.
And I'm Lisa, and today's episode is all about geriatrics. Because if you think aging is easy, we have news for you.
Spoiler alert, it's not for the weak, and neither is taking care of older adults as a nurse.
And we're not doing this one alone. We've got our friend Rob with us today. Float pool nurse, which means Rob sees every kind of patient, every kind of unit, and the ways aging shows up in real time.
Hey everyone, so Rob here, float pool nurse, like Lisa said, cared for older adults in med-surg, telemetry, ICU, neuro-ICU, almost everything except the ER pretty much. So geriatrics isn't a specialty you can avoid. They show up everywhere. It is everywhere, so happy to be here today.
We're happy to have you. I'm ICU, and Lisa's emergency room and interventional radiology, so float pool is basically the best reality check for how geriatrics hits every floor.
All right, so let's jump right into segment one, what geriatrics nursing really is. Let's start with the big picture. Geriatric nursing isn't just about treating diseases, it's about quality of life.
Quality of life is everything to me. So you always have to ask your patient what is their idea of their best quality of life. Fun fact that's not actually fun, about 80% of older adults have at least one chronic illness, and many actually have several, things like arthritis, hypertension, heart disease, hearing loss.
So our job isn't to fix everything, it's to help patients live as well as possible for as long as possible.
And yes, sometimes that means shifting the goal from cure to comfort and dignity.
And this is where nurses sometimes get stuck because we're trained to problem solve and fix things. In geriatrics, the win might be less pain, safer mobility, just trying to improve that quality of life that Chelsea mentioned a second ago. So we may not get to 100%. We're trying to get as close to 100%, increase that quality of life as much as we can. So bring the most joy back to them.
Yeah, fewer med errors, more independence. Older adults often have multiple chronic conditions, and that's where things get complicated.
Multiple meds, called polypharmacy, multiple providers, and providers never talk to each other. Have you noticed that? None of them talk to each other.
Yeah, and they all have different opinions.
Yep, and then same thing with family members. Sometimes they don't have any family. And that's us as the nurse advocate, right, to help them. And then sometimes they have multiple family members.
And then that one patient is stuck in the middle of all these meds, all the doctors, all the opinions, all the family members with their own opinions.
And everybody's making decisions for the patient except for the patient.
Yeah, it's terrible.
Mm-hmm. So goals of care, we always have to talk about goals of care, really in all patient populations and all ages, especially if they're very sick. But when you're older, it becomes inevitable. But goals of care usually include maintaining their own self-care and independence, managing their illness, and preventing complications from whatever disease process they have going on. Slow decline and help to support dignity. Even at end of life, there is such a thing as a good death.
Absolutely. This is where nurses shine. We're educators, we're advocates, facilitators, and professional barrier breakers.
So translation, we explain things, we coordinate care, we make sure the patient's voice is heard. You're really right at the center of everything, right? Everybody calls, who's the nurse for that patient? Lab calls, who's the nurse? Pharmacy calls, who's the nurse? Everybody wants to know who the nurse is.
Everybody wants us.
Yep.
And then in the different settings, you can really see the gaps fast. If the plan isn't clear, patient gets different messaging. Cardiologist will add LASIK, nephrologist will add LASIK, oh my gosh. Ignore me.
No, we want to hear what you have to say.
You'll have one specialist come in, and cardiologist will add LASIK. Nephrologist will come in and stop it because he doesn't want to mess up the kidneys. There we go. I got my thoughts out. Sorry about that.
So we can't even keep track of what the doctors want. How does the patient?
Yeah. Mm-hmm. Yeah. One orders something that's contraindicated by the other one, and nobody talks to anybody.
And a lot of times your older adults will pretend like they understand and they're following. Like if they can't hear, they'll just kind of nod and pretend, but they don't really.
Or they won't ask a question because it's the doctor and the doctor knows everything. Like that one doesn't.
Right?
Exactly. Yeah.
Not all doctors are good doctors, just like not all nurses are good nurses.
Yeah, that's kind of an oxymoron.
Mm-hmm.
Good doctor. Sorry, like 14 petite. Jumbo shrimp. Okay,
14 to
anyway.
teach
Yeah.
somebody.
Okay, so in nursing, assessment is everything. So let's talk assessment because in geriatrics, functional status matters just as much as vital signs.
Say it louder for the people in the back. ADLs and IADLs are key.
Yeah, can they bathe, dress, eat, toilet, those basic activities of daily living? Can they shop, cook, manage meds, handle finances? These are the instrumental activities of daily living or the IADLs.
And remember, assessment isn't one and done. Older adults need ongoing reassessment, especially during illness or hospitalization.
Also, family matters, including them in education and care planning improves outcomes.
Yeah, and so function tells the whole truth, the whole story. A patient can have fine vital signs, everything looks good on paper, and then they still shouldn't be at home, especially by themselves.
Yeah, can we talk about that a minute? How many times in the hospital when our patients are ready to get discharged, like medically they're good, but you're like, okay, we're going to send you home. And I'm like, really, doctor? Because this patient is 80 years old, lives alone,
Yeah.
cannot walk 10 feet. What if the house catches on fire? How are they going to get out of the house?
So this is something that maybe you can shed some light on for me as the ER nurse, because one of the reasons that I was always hesitant to work into the ER is because how many times do those patients get discharged when they shouldn't be? Like,
Yeah.
how many times do you see when you're reading your notes, like whether you're, regardless of what floor you're on, patient was here 6 hours ago and discharged,
Right.
and now they come back in as a cardiac arrest or something else. And
Right.
on the floor or in the hospital, if I know that a provider is discharging a patient that has no business being discharged, I would just call a rapid response
Yeah,
because they're going to look like a real ass if they discharge him now.
exactly. Or
But in the ER, what do you do?
yeah, well, that's always when we have to advocate. I can numerous times. So Lisa's personal opinion of life is I hate an HMO. So I don't like an HMO. I mean, I hear so many people that love their HMO. Good for you. I hate them because in my opinion, they make their money on short hospital stays.
Mhm.
And so they want to get you in and get you out, which most people want to get in and get out. I get that. But there are sometimes a patient needs to stay in the hospital a little bit longer.
Yep.
And so that is where my job as a nursing advocate really comes into play. I've got to advocate for those people. Use your voice.
Mhm.
Use your voice no matter how long you've been a nurse, how new you are as a nurse, use your voice. If you're not comfortable, talk to the doctor and say, I'm uncomfortable. And if they
Yep.
blow you off, one of my favorite responses is to say, okay, great. I just needed to know what to chart. And then they're like,
Yes.
wait, what? You're going to chart that? I sure am, sir.
Yep.
Or ma'am.
And sometimes you
And
can
use quotes.
Exactly,
Yes,
exactly.
absolutely. You always use quotes. We still have to be professional even when we're documenting what the provider said or
Right.
the patient said. So yeah, definitely put those in quotes. But sometimes we have to escalate our concerns
Yeah.
if we don't get those results we need, because that's our job as the patient advocate.
Yeah. So that's how I dealt with it in the ER. I
Yeah.
used my voice and you know, obviously the more I worked and the more comfortable I became, you learn how to professionally but very respectfully advocate
Mhm.
for your patient because at the end of the day, I'm not here to be a doctor friend. I'm
Right.
here to advocate for my patients, and that's really what matters.
Absolutely.
Yeah. Yeah.
So, yeah, patients might not be safe to go home, and
Yep.
we have to advocate for them to get them a safe place to go.
Yeah.
So education, wellness, healing mindset. Education is empowerment.
Yes, exactly. We teach older patients how to manage chronic illness, use community resources, and make realistic life changes. There's plenty of resources available. We just need to often help them find them.
Yeah, so older adults can learn. Sometimes you just have to present the information with a little bit more time allowed for that education. Things like treatment adherence, nutrition, safe exercise, stress management, and mindset matters.
A positive, supported patient does better than one who feels ignored or overwhelmed. And I want to give a little personal opinion on this one as well. Give your patient time to respond.
Right.
Sometimes, like my family, my parents sometimes can't hear or one of them can't really understand what you're saying. Give them time because they need time to respond. We were recently at an appointment with my dad, and the medical assistant was asking your medications and the vital signs and never giving him a chance to respond. And she almost got throat punched because nothing will irritate me more than if you take advantage of the vulnerable. And sometimes our older clients are vulnerable. Yes, I get you're in a hurry, but give it a minute. Let the poor man answer.
Yep.
He's smart. Let him answer.
And sometimes taking that extra moment to do things correctly saves you a lot more time in the end.
Yes, exactly. Yeah, because they're just frustrated.
I think that ties into we got to teach them in a way that works, right? So slower pace, maybe some more simple instructions, confirm understanding. In the hospital setting, I know it's something like 51% of people discharged can't tell you what their admitting diagnosis
Wow.
was. So
Wow.
obviously we're talking to
Shocking.
them, but the stress, the anxiety, everything that's going on, it's not getting through. So simple instructions, repetition, teach back. Again, it's just some other things too, like hearing loss, fatigue. They feel like crap most likely, and they're in the
Yeah.
hospital. So just a whole picture there.
And
Yeah.
thinking about that discharge starts at admission.
Admission. Yeah.
Because when it comes down to it in the hospital, how much time do they want you to have to discharge your patient, Rob, in the hospital? Like
Oh,
30 minutes, an
Like
hour?
once the order goes
like,
in?
Yeah,
Oh,
once the
well,
order
they
goes
wanted it 10
in.
minutes before the order goes in.
Right,
but,
yeah.
Exactly,
That,
right.
like they
Yeah.
actually have a clock ticking, right? Like
Realistically,
usually the
yeah.
discharge order's been in for this
Because
many
I'm
minutes,
calling
what's
you to put
taking
my
so
patient in your bed, and your patient hasn't even
Yeah.
left yet.
Yep.
Exactly.
And so we're trying to give them really important education, and we're not allowing the time to do it. So we have
Right.
to start teaching them earlier throughout the hospitalization and not waiting just until that discharge order
Right.
goes in.
Yeah, yeah, that's true. I mean, good point, Rob. Because like when our patients don't feel good, they don't understand what we're saying about discharge
Mm-mm.
plans.
They
don't
don't
feel
care.
good. Yeah, yeah. they
Don't try
want
to
it
talk to
now.
me when I'm hungry.
Exactly.
Yeah.
Right. Yeah. Yeah.
So, rehabilitation and frailty. So, let's clear this up. Rehabilitation is about ability, it's about restoring the highest level of functioning for that patient. It's not focusing on their disability.
The goal is to improve their function, independence, and their well-being, not to point out everything someone can't do. What can they do?
Right. So, now frailty is something that you need to be able to recognize. Warning signs include unintentional weight loss, weakness, fatigue, slow walking speed, low activity. I think that a lot of that comes with your intuition. You can kind of look at somebody and determine if they're frail or not.
Exactly.
And a lot of times they're frail, but they sure as hell won't admit it.
Exactly. Yeah, they fake it till they make it.
I
yeah.
had a lady the other day, I floated to the telemetry floor, and she was getting out of bed, and they had the bed alarm thing, like the pad with the box, and the box was mounted on the wall, and she learned how to turn it off. I walked by and
Sneaky.
she was up there turning off her own bed alarm, and I'm like, well,
That ain't
what are you
working.
going to do for this one? Yeah, I
Exactly.
don't know what to tell you, patient sitter, but that's the thing.
Strong-minded.
She's like, and she wasn't my patient, so I don't know, but she was easily over 80, if not older, very petite, very frail looking, walking around the room, turning off her own bed alarm. And
Love
I'm
it.
like, where do you draw that line between giving them their independence?
They have the right.
Yeah.
You have the right to fall.
Yeah.
Yeah.
Don't tell that to admin.
Right. But they do have the right.
do.
Like if we
Yeah.
put all the implementations in place and you bypass those, that's on you,
What are you
boo.
going to do?
Yeah, exactly. Yeah. Yeah. So frail elders are at higher risk for falls, hospitalization, and nursing home placement, and even death. So frailty is a big deal.
Yeah, a hip fracture can set you back pretty significantly
sure
when you're
can.
older.
Yeah.
And when you're older, that's when you don't really want to be losing weight. Like your whole life, you're like, oh, I'm trying to stay, but
Shed a few pounds.
Yeah, but when your older adults start losing their weight, that can be a bad sign. Early recognition of frailty will lead to better outcomes.
Yeah, and that frailty should change how we plan everything. So mobility goals, discharge timing, fall prevention, pain control, how aggressive we push rehab. Back to your hip fracture example, when I worked in hospice, too many times I would see an elderly person fall, and then the hip fracture would set off the whole cascade, and then into the hospice setting solely just because they lost mobility and everything, unable to really move or live their life in any quality way.
My
Yeah.
motto is the bed is what kills you.
Yep.
The bed is absolutely what kills
Yeah.
you. My patients do not eat in bed. If my patient is healthy enough to eat, they need to be doing it in a chair, even if it's that Cadillac Neuro Jerry chair. Yep, the bed is what kills you.
Sit up. Yeah,
Mhm.
beds should be classified as like a murder weapon.
Absolutely. And, I'll see some nurses that are like, oh, well, the bed has the chair position. Not the
No.
same.
Yeah,
Not
their
the
butt needs
same.
a different
Yep.
surface to
Yep,
sit on.
You got to move your patients.
Absolutely,
Yep.
yeah.
And you do not have to wait for physical therapy to get your patient out of bed.
Yeah, last I checked,
Yeah.
we are nurses.
Yep.
We are
Yeah.
educated for such things.
Right.
Yes.
Yeah. Unless they have contraindications like a DVT or, something like that.
Yeah.
Move them.
Yeah. Yeah. And speaking of movement helps ease pain and promotes comfort. So really this is the big one. Pain is one of the greatest threats to comfort in the older adult.
So pain, it's subjective. It's what the patient says it is. If they say they're in pain, believe them.
Yeah, there's different types of pain, neuropathic, persistent, or chronic pain, or acute pain.
Yeah, and unrelieved pain leads to immobility, pressure injuries, which cause more pain, pneumonia, that is what kills you. Constipation, maybe from not moving around, even though that can be one of the side effects from some of the opioid pain medications. Depression, that's huge. And straight up hopelessness.
Yeah. Pain
Hard.
assessment
Oh, I
should
was just going to say it's hard to enjoy your life if you're feeling
It
miserable.
is, yeah, pain all the time. Chronic painers, I just feel so bad for people.
Mhm.
Like, like the other day, like I hurt my pinky. You never realize how much you appreciate a
Right.
healthy pinky until yours
Yep.
hurts, right? You like don't even use it, but when it hurts all the time, you think back to those times. I remember the day when my pinky didn't hurt. Yeah.
Right?
Yeah. Pain assessment should always use open-ended questions, a detailed history and frequent reassessment, especially in patients with cognitive impairment. And this, again, is where I'm going to add my personal imperative. Give the patient time to respond. Wait it out. Let the patient speak. You can learn a lot when you let your patients talk.
I had a hard time. Oh, sorry,
No, go
Rob.
ahead.
I had a hard time with that with the nursing students. I don't know if you all had that at first, like
Yeah.
that awkward silence where you have to let them think and you want to answer for them, but like, no, just give them time to
Yes.
think and process.
Exactly.
Mhm.
Yeah. Yeah. A lot of learning happens in the
Yep.
silence.
Right. And that silence, it can feel awkward, but it's useful with the students, useful with patients. Sometimes with the silence, they're feeling depressed, like somebody said earlier. I don't remember which one of you. Sometimes somebody just wants you to sit there with them, and you don't even have to say anything. The silence can be therapeutic in itself. But
Yeah, sometimes I'll even take my wow and I'll just sit in that patient's room and chart,
Yeah.
like just to be in there with them.
Yep.
hmm
Yeah.
And I found nursing tip, like, don't try to chart at the nurse's station. You will
Yep.
never finish because the phone is going off. People are coming up and talking to you. I chart at the bedside. Even if I'm like going back to the bedside, I go
Yeah.
there and then I can look at the patient. If I'm like, oh shoot, I forgot to look at the
Exactly.
pedal pulse. Like I
Yeah.
can just check it really quick.
Exactly.
So and that's how I get out on time because there's some nurses that milk the clock, that double time after 12 hours. 12 hours is enough. 7:23, I'm out.
Yeah. And they watch that, right? If you have too much double time, you go
Yeah.
and get fired.
Mm-hmm.
But yeah, exactly. Yeah. Yeah.
So pain management is going to be very individualized. Providers always use the saying start low, go slow with meds. Use non-opioids first when possible and combine with non-pharmacological therapies. Please, Lisa, if I'm dying, do not give me like guided imagery or music. Put me on a morphine drip.
I'm just going to put a pillow over your face.
That's fine.
There you go.
Just, yeah.
Yeah, exactly. Yeah. But sometimes a massage, heat or cold.
I'll take a massage.
Yeah, right?
I don't want the guided imagery. Just give me morphine drip.
Think of a waterfall.
Well, you could do that while the morphine drip is
There you
going.
go.
That
Well,
could be a
yes.
nice experience. Yeah.
There you go. Like
Yeah.
end on a high note. Exactly. Yeah. Don't underestimate the power of
Don't
just
be like,
being
well, it
there.
might slow. You hear some nurses, well, it might slow down their respirations. They're
They're dying.
dying.
Yeah, this is the point.
Yeah,
Exactly. I
exactly.
hear that.
Yeah.
Yeah. Yeah. And like I think the thing too is being there. And you were talking about charting in someone's room, like the presence just being there. If if you spend time charting in your patient's room and you even letting them sleep,
Yeah.
they will feel your presence there. And then when someone says, "Hey, has your nurse responded to your call bell on a timely manner?" Even if you didn't, they knew you were there.
Yeah.
And so satisfaction scores are so much higher.
Yep.
Is it uncomfortable for us? Sometimes, but don't like 24/7 ask your, "Are you okay? You feel good? Are you feel okay?
Yeah.
You okay? You feel good? Are you okay? Can you feel that? Does that
Yeah.
hurt?" No, just be
Right.
there.
Yeah.
Shut your mouth, do your work,
Yep.
and be there.
Yep. Yeah, and you know which patient, needs that, which one needs you and which one doesn't. If I've got like a
Exactly.
30-year-old walkie-talkie, I'm
Yeah.
I'm
See ya.
leaving them alone, giving them their privacy. But if I've got like a 70-year-old who's like full of cancer, like, yeah, I'll sit in that room and
Or
chart.
even lives alone, wants to chart,
Exactly.
wants to chat.
Yep.
Absolutely. Yeah. Read the room. That's what you got to
Yes.
do. Yeah. All right, Chelsea, before we get serious again about aging, frailty, and chronic pain, I think we need a quick, unsponsored moment.
From someone who doesn't pay us. All right, nothing says gerontology like an imaginary product.
Exactly. Today's episode is not sponsored by, but should be, SteadyPal.
SteadyPal, for when your brain is confident but your knees did not get the memo.
It's designed for older adults who say things like, "I'm fine," right before standing up and immediately reassessing every life choice.
SteadyPal features balance boost mode because gravity gets more aggressive with age.
And anti-shake stabilizers, so when you reach for your coffee, it ends up in your mouth and not watering the houseplants.
But my favorite feature, stand up sound dampening.
Yes, because standing up after 65 should not sound like popcorn and bubble wrap having an argument.
Also included, chronic pain translator. It converts "I'm fine" into "I hurt everywhere, but I don't want to be a burden."
And that's the part we joke about, but it's also real.
So real. Aging bodies carry chronic pain, stiffness, fatigue, and a lot of resilience. Frailty isn't weakness, it's vulnerability layered on top of decades of strength.
SteadyPal doesn't promise to fix aging. It just says you've carried a lot. Let us help you carry today.
It even has a room entry reminder gently whispering, "You're here for the remote. It's always the remote."
Honestly, I need that feature right now.
Same. Aging is just a future us with better stories and more joint pain.
So, while SteadyPal is fictional, the need for patience, dignity, and compassion for older adults is very real.
Be gentle with older people. Their bodies may be frail, but they're carrying a lifetime of experience and often chronic pain you can't see.
And one day, we'll be the ones standing up slowly, making eye contact with the couch and negotiating.
And hoping someone treats us with the same kindness.
All right, welcome back to Just Hard. Let's pick up where we left off and bring this into real nursing practice. Joking helps us cope, but caring requires us to look deeper. So let's meet someone whose experience reflects many of the things we just laughed about.
Yeah. So let's shift back into nurse mode a little bit. Laughing is good. It's healthy, good for us, fun times. But when we talk about frailty and pain, we're really talking about safety, function, dignity. Let's walk through a real-world patient and listen for the red flags.
As we go through this case, we challenge you to listen not just for symptoms, but for signs of frailty, chronic pain, and unmet needs. So, patient 1, let's meet our patient for this episode, Mr. James Carter, 82 years old, lives alone in a one-story home. Medical history: arthritis, hypertension, heart failure with an ejection fraction of 40%, and age-related hearing loss. He tells the nurse, quote, "I don't want to be a burden. I just want to stay in my home."
Yeah, and when someone says that, saying that I don't want to be a burden, a lot of that is they fear losing independence. That should shape priorities, teaching, discharge planning. Just focus on them as a holistic being, a whole person there.
Yeah. So I have a pause and think question. So, of this, which nursing priority that I'm going to list best aligns with Mr. Carter's statement? Do we think about aggressive management of heart failure? Is our plan education on disease process? Is it supporting independence and quality of life? Or is it preventing all future hospitalizations?
Ooh, I bet if we asked a classroom of 100 nursing students, we would get all of those options picked at least once.
I agree with you.
So I would say I have to go back to my test taking strategies. What is the question asking you? Like, so so what best aligns with Mr. Carter's statement? I don't want to be a burden. So supporting independence.
Absolutely. Geriatric
Yep.
care focuses on patient-centered goals, especially independence and quality of life, not just control.
All right. Mr. Carter is admitted with an exacerbation of heart failure. He reports increased knee pain from arthritis. He has 9 daily medications.
This is real life, people. Multiple chronic illnesses, multiple meds, and one patient trying to manage it all.
Yeah, polypharmacy going on with 9 daily meds, that's a whole thing of its own. If nobody can explain why, when adherence falls apart, I don't know about you guys, but if somebody just tells me do this and doesn't want to explain it, it does not help me very much. I don't really pay attention to them. I need to know what's going on. I had a doctor tell my mom one time, just take this Xanax because I'm the doctor. I told you so. And
Oh, wow.
yeah, that didn't go over very well.
Let me
but
tell you
yeah.
what to do with this Xanax, buddy.
Yeah, time for a new doctor. Yeah.
Yeah.
So, and how many times in the hospital, and I'm not just saying like, we're talking about the older adult at home, but how many times in the hospital on a patient that's admitted do they have conflicting meds?
Oh, yes.
I guarantee you if we walked onto a telemetry unit, we would find at least one patient that has antihypertensives and midodrine.
Exactly. Yeah.
Like, how many times do you see those conflicting meds, even in the hospital setting?
Yeah. One brings
So
the blood pressure up.
that's like,
one
did
brings the
nobody
blood
think
pressure
about this
down.
for
Yeah.
days?
Yeah. Is no one actually assessing what's going
And
on?
thinking about what's happening. So yeah, Rob, 100%. Like, always think about what you're doing and why. If nurses are always afraid, like, I don't want to lose my license. As long as you know what you're doing and why you're doing it, you'll be fine.
Yeah, you're going to lose your license if you don't think.
Yeah, 100%.
Yeah.
Yeah. So, okay, so back to your pause and think question.
Yeah. So this is another question, right?
Right. Okay.
Yeah.
So, which nursing action best addresses the challenges of multiple chronic conditions? A, teach med names only. B, coordinate care and simplify the med routine. C, focus on the most serious diagnosis only. And D, deferring education to discharge.
Yeah, so polypharmacy, we don't know when, we don't know why, we don't know what we're doing. It often looks like non-compliance when it's really just confusion. So I think the best thing for this one is that we need to coordinate the care and simplify the medication routine.
Yeah, I think so too. That also test taking strategy, if you don't know, like, right? So start with what answers the question, what addresses the challenges of multiple chronic conditions. Coordinate care and simplify it, right? And it's, you want to be, we don't usually want to go for things that say only, always, never,
Yeah.
those absolutes. Sometimes that's the case.
Medicine, there's
yeah.
always an exception to every rule.
Yes. Yeah.
Yeah.
So coordinate care and simplify the med routine. Nurses are facilitators and advocates.
Yes. So during assessment, the nurse learns that Mr. Carter is independent with bathing and dressing. He needs help managing his medications, and he struggles with grocery shopping due to knee pain. His family lives 2 hours away.
Do you think he knows how to use Instacart?
Yeah. Ooh. Yes, there you go. You could make an app for that. Like, I mean, not the Instacart app, we know that, but like a geriatric Instacart app.
version?
Yes.
Oh,
there you go.
yeah.
Now we're thinking.
Maybe we could create the app and they would sponsor us.
Oh, ooh, I like it, Chels. I
Mhm.
like the way you think. All right, so let's do, now that we know a little bit more about Mr. Carter, let's have another pause and think. So which findings are most concerning for Mr. Carter's ability to remain safely at home? A, he needs help managing his medications. B, he lives alone. C, he has chronic arthritis. And D, he's hard of hearing. So what do you think?
It's going to be A, needs help managing medications.
Yeah, because I mean, living alone, you can do that. You can have arthritis and you can be hard of hearing, but not managing your medications is a problem. Yeah, medication management is an instrumental activity of daily living. It's critical for his safety. So the difficulty here increases the risk for adverse outcomes.
Yeah, if meds aren't managed safely, everything else becomes riskier. So nurse discusses these medication and lifestyle changes with the patient, dietary changes. That's probably the hardest thing to do. Wouldn't you guys agree?
Yeah, so what dietary change does this heart failure patient need?
Well, he needs low sodium
Yeah.
and fluid restriction. I wouldn't adhere to that, would you?
No, not in the summer.
No,
Yeah,
no.
no.
But they have to, or else they're like
Right.
literally drowning. Yeah.
Yeah.
Mm-hmm. And then gentle exercise, of course. And so we can refer to Mr. Carter to some of these things. And as a bedside nurse, we might not know all those resources out there. That's okay. You'll learn them with time. You can have case management help you out.
Yeah. Yeah, so you tell Mr. Carter all these things, then he all of a sudden says, I didn't know there were resources like that.
Yeah. Yep. So what statement by the nurse best supports health promotion? A, your condition will worsen no matter what you do. B, let's focus on what you can control to stay independent. C, your family will eventually need to take over everything. Or D, avoid all activity to prevent fatigue.
Best support health promotion. Well, no matter what you do, your condition's going to get worse. That's not promoting anything.
Might be true, though.
It might be true, but that's not promoting health. My goodness.
That doesn't answer the question.
Yeah, that's kind of rude. Yeah. Your family will need to take over eventually. That's not health promotion. Avoiding activity. That's not
That's
health
never good.
promotion. So the only one left is B. Let's focus on what you can control and stay independent.
Agree. Education empowers older adults and supports a healing mindset, which improves outcomes.
Yeah. Okay, so on hospital day 2, the nurse notices unintentional 10-pound weight loss in 6 months, that Mr. Carter has a slow, unsteady gait, and he has fatigue with minimal activity. So now our pause and think, what do those findings most strongly suggest? A, normal aging. B, acute illness only, keyword. C, frailty syndrome. Or D, depression.
C, frailty syndrome for sure.
Yeah, those indicators, weight loss, weakness, fatigue, and a slow gait, are hallmark signs of frailty, increasing the risk for falls and hospitalizations.
And then this comes back to safe discharge, like we talked about earlier. I don't want to send them back into an unsafe environment, especially if they live alone, like we talked about earlier.
Yeah, frailty definitely changes that.
Yep. So Mr. Carter rates his knee pain at a 7 out of 10. That's worse with movement. He grimaces during repositioning, but minimizes pain verbally. So what is your best action? A, assume the pain is expected with arthritis. B, delay assessment until he requests medication. C, use open-ended questions and observe nonverbal cues. Or D, document pain as moderate.
Ooh, well, I think we know communication is key, right?
Mm-hmm.
So I would think we need to use open-ended questions and observe those nonverbal cues, because sometimes older clients will not admit they hurt.
Nope, they will not.
Yeah, they leg be hanging off. They're like, I'm
Right.
fine.
Yeah.
Yeah.
Yeah, absolutely. I agree. They minimize it all the time. You got to assess it and make sure you're getting a fair assessment, a true assessment as well.
All right. So which pain management plan is most appropriate? A, PRN opioids only. B, scheduled non-opioids plus heat and movement. C, avoid pain medications altogether due to age. And D, bed rest to prevent discomfort.
Well, we talked about how bed rest will kill you, so we
Mhm.
know that one's not going to happen. Avoiding pain medication due to their age isn't nice or fair. Obviously, we know there's other side effects that happen. as
Right.
we
And there's
age.
certain criteria, like they have the Beers
Beers, yeah.
criteria and stuff for medications to avoid, but we don't want to avoid it altogether. There's always something you can do.
Exactly. PRN meds only, that's not helpful. We might need to do other things. So our obvious answer here would be scheduled non-opioids plus heat and movement. Yeah. Sometimes basic Tylenol will just help. That's all you need.
I think insurance should cover a hot tub.
Oh, and massage.
Yes.
Yes.
I don't know why it doesn't.
Yeah, that's rude.
Yeah.
Yeah, I got you.
So older adults benefit from multimodal and individualized pain management treatment. So Mr. Carter is finally discharged with home health nursing, a pill organizer,
I love it.
physical therapy, and community meal support. And he says, hey, I feel like I can handle this now.
All right, so this is our final pause and think moment. Which nursing action most contributed to Mr. Carter's positive outcome? A, treating his heart failure aggressively. B, completing all the required documentation. C, holistic individualized care focusing on independence. Or D, limited family involvement.
Holistic, individualized care focused on independence. Geriatric nursing succeeds when care is holistic, patient-centered, and dignity-preserving. So what's the takeaway?
Can I add to that?
Yeah.
The holistic being part is a very important concept. So it's not just the body that we're trying to fix. People are mind, body, spirit. Not to sound too spiritual or mystic or anything, but we're more than just a physical shell, and we got to take care of the whole person. I think that's sometimes the problems with the doctors, like we talked about earlier, the medical model too much, too focused in on just getting rid of the UTI, and they forget that that's actually still a person standing there or sitting there in front of them.
I love that.
Yeah, a patient with needs that are not always just related to the UTI. Maybe the UTI happened because they are immobile, or they are incontinent, or they have poor dietary practices, or they live without adequate hygiene because their facility doesn't provide that. There's so many other reasons. You're so right, Rob. That holistic thing is, I used to think, I'm not going to lie, when I was younger, I was like, oh, that's Pollyanna. Let's just treat them and street them, right? That's the ER paramedic in me. But I realize it's so much more. How much more do your patients improve when you actually get to know them, spend time with them, and really understand them at a deeper level? And this is
Absolutely.
more, for those of you administrators listening to our podcast, this is more than that 12 minutes a day that we are allowed to spend with our patients. We need to spend time. We need to get to know them, because you allowing me more time with my patients improves outcomes. And this is where our nursing colleagues need to recognize that time that we have that's extra is not time to sit at the nurse's station and visit.
Thank you.
Get in there, talk to your patients, and do what we're paid there to do. If you want to spend time with your colleagues, go out afterwards, or go out on your day
Or
off.
spend time together in the patient's room.
Yeah, go together.
Yeah, involve the
Exactly.
patient when you're, having a conversation, appropriate conversations, of
Exactly,
course, with
obviously.
your patient. But
Yeah. Yeah, good point. Yeah.
So we support independence, manage pain, prevent complications, protect dignity, watch out for signs of frailty in the older adult populations.
Yeah, and it's going to be the same across ICU, into the ED, like Lisa works, IR where Lisa works, Chelsea's at the ICU where I've been, and my med-surg telemetry background. It's all going to be the same common thread. Those older adults are going to do best when nurses see the whole picture, the whole person, not just the diagnosis.
Yeah.
We're not fixing a broken car.
Exactly, yeah. Aging is hard. It's just
hard.
But good nursing makes it better.
That's real talk.
From real nurses living real life. Because nursing is hard, and we can do hard things.